Hello, this is the introduction to issue taking in pediatrics by the SchrDbb with reference the practical guide of issue taking and clinical examination by Anwar Qais Saadoon. Hello, in this tutorial we are going to see how to do general issue taking and physical examination in a pediatric patient. Okay, so we are going to start. So you're going to have introduction. So you have an introduction. You have inside the issue taking. You should know that there are certain elements in pediatrics, in issue taking of pediatrics, that you should have as a student when you want to take issue taking in pediatrics. So in that format, you're going to have the identification. You're going to have the presenting complaint, then the issue of presenting complaint. Then at times we can place the review of system directly below the issue of presenting complaint, or you can place the review of system after the issue or after the pass issue. Now, placing it before and after the pass issue depends on how you want to make your issue resemble. Example, when you place your review of system after the pass issue, it means that what? It means that you want to review the system of the new day. But when you place your review of system before the issue or before the pass issue, it means that you want to review the system of that day. Example, you receive a patient who has fever and then abdominal pain, and then he made 5 days in the hospital. So you are seeing him on day 5. On day 5, when you are going to write the review of system after the pass issue, it means that you are not going to, the patient may not have fever and abdominal pain again. So the fever and abdominal pain has gone because of his progress in the work. So when you use it after the pass issue, it means that you are not going to visualize again those reviewed symptoms. So reviewed symptoms like chest pain, it may not be present again because the patient has already been reviewed in the ward. But if you place the review of system now before the pass issue, try to review the system that the patient had on that day, you may have further elements that's going to back up your diagnosis. So it depends on the position. It depends on how you want to make your issue resemble. Another example is if you receive a child who had intestinal obstruction, presented with constipation and then vomiting, and then an operation has already been done. You see that you can review the system before the pass issue to bring out all the elements of intestinal obstructions, or you review the system after the pass issue. If you review the system after the pass issue, it means that you want to bring out the review system of the day, and in that review system you're going to try out the post-operative complications. Like you review the cough to find if there's any post-operative hypoxia, you review the chest pain if there's a post-operative myocardial infarction or ischemia, you review all the review fever for post-operative pyrexia. So these are all the elements. Generally, that's what you have to have in mind. Now let's continue. So you have the presenting complaint, you have the issue of presenting complaint, you have the pass issue. Now under the pass issue, what are the elements you have? At the beginning, you first have the antenatal. In the birth issue, you first have the antenatal care. The second thing, after antenatal care, you have the labor issue, which consists of the birth issue. So in the birth issue, the elements which are here, the first thing we have the prenatal care, the second thing we have the antenatal care, the third thing we have the labor issue, the fourth thing we have the neonatal issue. So these are all the elements that you bring out inside the birth history. So the first one is the prenatal care, is the history that you're going to bring out before the patient before the patient gets born, or the antenatal care. The second one now is the labor issue, is a issue that took place as the process of labor was taking place. The next one is the postnatal and the neonatal issue. Postnatal is the issue directly after birth, and the neonatal issue is the issue after birth till 28 days after delivery. Then you're now going to speak about the past medical and surgical history. Then later on, you speak about the medication history. We have also things which are very important in pediatrics, such as the developmental history, the immunization history, the feeding and dietary history for an infant and for other children, and then we have family history and social history. But at times, since this developmental history, immunization history, and feeding history are more important for children, you may place the past history, be the past medical and surgical history, after these three histories, which are developmental history, immunization history, feeding history. We place them after and place it here. So we place past medical, then surgical, then family, then social, and then you end up with your review of system, or you begin up with your review of system. So we start off with the introduction. So in the introduction, you must know how to speak to a patient. So that's the first point you have to know. So you need to know that a child is not as an adult where you can discuss with a child directly. So you are going to discuss mostly with the patient that is taking place, which is more active with the health of the child. So in this case, you have the informant, and the informant usually should be the mother, who is very active. And according to the saying of August Beers, he said that a smart mother makes often a better diagnosis than a poor doctor. So if you discuss very well with the mother, a mother that takes care of her child very well, she's going to give you a very good view of what happens with the child. So and also you need to know that a child is not like an adult who can be easily cooperative. So you're the one that is supposed to create a playing environment or a soft environment for the child to reveal himself to you. So you have to, the examination room at the beginning, the examination room has to be very comfortable for the child. The second thing is that you yourself, you have to obstruct any barrier between you and the child and open up yourself to the child, so that the child leave you to examine himself. And you can also ask some certain questions in older children. If you have children of greater than 6 years who can give some of what happened to them, they can decide, they can give you. So that's the generally introduction. An introduction, you need to know how to ask your questions. So I'm going to tell you that later, but those are the points that you have to put in mind. Now, also as an introduction, you need to know the newborn is starting from the first day of life to 28 days of life. That's the first month. The infant is from the first month to the 12 months of life. The toddler is from 1 year to 3 years. The preschool is from 3 years to 6 years, but sometimes people say from 3 years to 5 years, and then the school children from 6 years to 12 years, or sometime from 5 to 12, and then the adolescents from 12 to 18 years. And so other considered adolescents to be from 10 to 18 or from 12 to 20, depending on the location. Like in Cameroon, so an adult is considered only as from 21 years, so it's going to much more applied for 12 to 20 years. But usually what is globalized in worldwide is 12 to 18 years as being an adolescent. So the other elements of the issue of medication history is there are certain drugs that can result to a pathology. We have developmental history, we have immunization history, feeding and dietary history, family history, social history, and review of system. So we continue now with the presenting the identification of the patient. To identify the patient, the general mnemonics is NASARTI, NASARTI. NASARTI. That's a general identification of a child. So if you have a child that is an infant, that's an infant and above, that's 1 to 12 months and above, we are going to present the child with NASARTI. N for the name, A for the age, S for the sex, A for the address, R for the religion. So this is a worldwide book. So you R for the religion, T for the tribe. But since this book is an international book, at the place of the tribe you are going to have ethnicity or race. But in our context, you write the tribe. If it's a Bamileke, if it's a Bassa, you write it. And then you have I for informant. Informant is a mother. Then you can add others like the date and the time of admission. So we have the informant and the date and the time of admission. So those are the elements. So if you and the mode of admission, so you can also note Nazatidem. So N for a name, age, sex, address, religion, tribe or ethnicity, informant, the date of admission, and M for the mode of admission, and that's the source of referral. So those are the points that you have in the identification. Now after the identification, the next thing, and they are telling you here the reason why it is good for you to identify a patient. We need to know that what we need to know that the identification just by sex is very important, because diseases identification, the name is important because you just need a name to easily have a good relationship with your patient, with the child you're speaking to. The second thing is the age. The certain diseases which are more common in neonates than in older children. Example, if you have a disease where you realize that there is a malformation of a face in a child, so you are going to mostly consider a pathology which is going to be congenital than rather having a malformation in adolescence. So if you have malformation in childhood, you can consider easily congenital diseases. But if you have malformation in adolescence, you can think of it instead of an infectious disease that occur later in life and not congenital. So that's on the age. On the sex, there are certain diseases which are sex linked. Example, we have hemophilia and Duchenne muscular dystrophy, which are more commonly X-linked and more common in male. The second one is the birthplace. A certain location in Cameroon that are more prevalent with certain diseases, like the dam places, which are much more common with onchocerciasis for follow. So if you have a patient having coming there, you can easily come with river blindness. So those are the points that you have to know. So that's the address, and also certain address in Cameroon have more prevalent mosquito compared to the others. So if they come there, you know that if you certain address in Cameroon have more prevalence of having cholera, so you have to know the address. The next one now is the tribe. In the tribe, there are certain tribes which are more common with certain disorder than the others. Example, in the Bamileke tribe, it has been shown that most of the time in the Bamileke we have the gene of albino. So the albino gene comes mostly from Bamileke and all that. So that's why you have to know the ethnicity. That's the tribe. The next one is for religion. The religion, just that it's not really tool to emphasize, but just that you have to know religion. Like for Jehovah Witness in our context, they don't like to take blood. So in that case, you must either sign a consent form, or you must find another way out to help the patient without giving him blood, because they don't like it. You should always respect the patient in every situation that you have. So the patient is the one that is going to propose all your possible management to the patient, and the patient is the one to take the final decision and the consent. So the next one now is and also we say that there are certain races, ethnicity, like the Kawasaki disease, which is a form of heart failure in a child. It's not possible for you to have heart failure in a child, but when you have heart failure in a child associated with certain forms of rashes, that's Kawasaki disease, you think that it's going to be much more present in Japanese children. Acquired lactate deficiency and Sickle cell is much more common in Africans, and acquired lactate deficiency common in African American and Asians. So we continue with the chief, the presenting complaint. Okay, for the presenting complaint, you just ask the question, what is the main problem? So here you don't want to know yet the presenting complaint, just want to know the exact symptoms that brought the patient to the hospital. So just ask him, so what are the problems that brought you to the hospital? So that question he's going to list, and usually the list should not be greater than 3 problems. So the presenting complaint usually should not be greater than 3. That's a list of 3 and not more. And now, so that's the only thing you have to know in the issue, the presenting complaint. Now the issue of presenting complaint. Okay. So in the issue of presenting complaint, before we go out to know what is written inside the book, I just want to give you a general point. You need to know that as being a good medical doctor, there's a general principle for you in taking a issue of presenting complaint. You don't just take a issue of presenting complaint for the issue's sake or for your lecturer. No, you take a issue of presenting complaint for certain principles. So in your issue of presenting complaint, you try to sort out the disease. You should try at the end of the issue of presenting complaint, one should sort out the disease you want to speak about. At the end of the issue of presenting complaint, one should rule out other diseases from your issue of presenting complaint. At the end of the issue of presenting complaint, one should find the complication of that disease in the issue of presenting complaint. And at the end of the issue of presenting complaint, one should find out the cause, or you may also find the cause in the past history. So those are the 4 elements that when you finish your history and your past history, one should find it out, all of them. You have the disease, the presenting disease. You have ruling out other differentials. You have the complication, and you have the cause of the presenting disease. So those are all this. So let's take an example. You have a child that presents with flank pain. We present with flank pain and fever. So when you have flank pain and fever, you must already know your semiology. So we are going to see the symptoms, and you have to know already the different pathologies that go with a particular symptom. That's why the presenting complaint is already very important. So when you have the presenting complaint, let's say fever, flank pain. So when you have fever, flank pain, just write the differentials of fever, flank pain that you know on your paper. So when you write the differential of fever and flank pain, now you continue now into your issue of presenting complaint. You already have one differential, which is already acute pyelonephritis. Okay, so that's one, which is found in the flank. You have acute pyelonephritis. You can have a urethritis. You can have that's upper urinary tract infection. You can have a colonitis. So a colonitis, you can have anything that can affect also the colon, like Crohn's disease, ulcerative colitis, and all that. So you can have it. Those are diseases all through. So in general, you have the urinary tract and you have the GIT, which are affected when you have a fever and flank pain, depending on your anatomy, because the structures found in the flank are the kidney and the ascending and descending colon. Okay, so when you have this type of patient, you first start by bringing out your diagnosis. So you are going to first describe the fever very well. In acute pyelonephritis, the fever is much more of a constant type. The patient is always going to have a constant type of fever. And now the difference that you are going to bring out in the acute pyelonephritis, that you are going to tell your examiner that it is much more of an acute pyelonephritis than a colonitis, is the fact that you bring out the fact that the patient had he first had pain while urinating. That's dysuria. The patient first had pain while urinating, and then later on he first had pain while urinating. He had the hematuria, that is blood in urine, and then later on he started feeling now pain in the flanks. When you say that like that, you are talking about the pathophysiology in which acute nephritis occurs, because there are two ways via which acute nephritis can occur, and the much common route is going to be via an ascending urinary tract infection. It starts from the lower urinary tract. That's why he's going to have pain when urinating, and he's also going to have hematuria, and then it goes to the upper urinary tract, that is the urethra and the kidney, where he's going to have now fever and flank pain. I hope you understand. So in that your history, you bring out the fact that there was an ascending urinary tract infection to rule in your diagnosis of a urinary tract infection. Now, how do you rule out? You now say that there was no rectal bleeding or hematochezia, that the patient did not have a bleeding in the feces. He did not bleed through feces. There was no melena, there was no bleeding in the feces. When you say that, you are trying to rule out any pathology in the colon. The second thing that you try to rule out in the colon is diarrhea. You try to rule out constipation. You try to try to rule out abdominal swelling. So all that you rule out for symptoms from the colon, to say that your symptoms are mostly the urinary system and the urinary tract. So that's how you can do. Now the next thing is, what is the cause now of that urinary tract infection? So you bring out now the next thing that you have to bring in the issue of presenting complaint is the complication of urinary tract infection. So how does acute pyelonephritis complicate? But acute pyelonephritis can complicate to sepsis. So you try to bring out all the elements of SIRS in your issue of presenting complaint. So SIRS is syndrome of is signs of inflammatory response syndrome. That's SIRS. So you try to bring it out in your issue of presenting complaint. How do you bring it? You know the elements of SIRS are: you have you have tachycardia, that is a heart rate of greater than 90 beats per minute. You have tachypnea, that's a respiratory rate of greater than 20 cycles per minute. You have fever with a temperature of greater than 38.5 degrees Celsius. So you try to bring it all the elements. You ask if the patient has taken the temperature at home, and if the temperature was greater than 38.5, he's going to tell 38.5 is going to tell you yes. So that's already one element of SIRS. You ask if the patient was breathing fast, or if the patient was feeling heartbeat. So those are elements for increased heart rate and increased respiratory rate. So after that, you are trying to bring out the element of sepsis inside your issue presenting complaint. So the other differentials, again, you need to know other complications of acute pyelonephritis. You need to know that every time you have fever, you are at risk of having dehydration because of insensible water loss. So you should also try to bring out the elements of dehydration into your issue presenting complaint. All those elements you are going to bring it as we are going to evaluate inside our tutorial. Now you can now bring the cause now of your acute pyelonephritis in the past history. And where do you bring in the past history? You're going to bring in the social history example. You need to know that the most common cause of urinary tract infection in a child is because of poor hygiene, because the child doesn't know how to clean their feces. They clean from back to forth, while they have to clean it from forward to backward. And that in the most people who are at risk of having those type of urinary tract infection are females, because the urethra is very small. So those are the cases that you have to bring out. You also have, if you have a child, a very young child that presents with the urinary tract infection, you should think of any form of urinary outflow obstruction. You should mostly think, if you have a child that presents with recurrent urinary tract infection, you must think of the cause of that recurrent urinary tract infection as being an outflow urinary, a urinary tract obstruction. And the most common cause of urinary tract obstruction in males, so if you have a male coming with a recurrent urinary tract infection, you should think of a posterior urethral valve. That's the most common cause. And then in females, you may think of a hematocorpus, that's a diaphragm in the vagina obstructing the urethral flow. So those are all the elements. So the next one, so those are the points. So so those are the elements. So now under your issue of presenting complaint, what are you going to describe? So to have the issue of the presenting disease, you should describe the symptom. So you are going to describe the onset of the symptom, you are going to describe the duration and the time of the symptom, you describe the predisposing factor, you describe the site and radiation if it is pain, you describe the characteristic, the severity of the symptom, the frequency of the attacks of the symptom, the progression of the condition, the aggravating and the relieving factor, the associated symptom, the predicting complication, and all that. So the type of symptom, if it is sudden or gradual. The duration if it is acute or chronic. Example, you have a cough which is less than 2 weeks is acute. A cough which is greater than 2 weeks is chronic. The timing is if it is intermittent or if it is constant. So that's the timing. The predisposing factor, what predisposes you from to have that particular symptom. The frequency, so the progression of the symptom, the aggravating, what make it to be aggravated and relieved and all that. You are going to see the description all down. Now there is a particular mnemonic series which is used when you have pain. If you have a pain symptom, the mnemonic is going to be Socrates. Socrates, S for site, that's the location of the pain. O for onset, if it is sudden onset or gradual onset. C for character, if it's crampy, if it's throbbing, if it is piercing, so character. R for radiation, where does it radiate? And usually when you want to speak about radiation, you must know your dermatomes. Example, the heart, if a child says that he complains of a chest pain and you think that it's the pathology of the heart that receive this the cardiac plexus receive the nerve root from T1 to T4. Are you getting? So the cardiac plexus receive from T1 to T4, and now so that's why the pain of the heart is going to be located on the dermatome of T1 to T4. And also you need to know that what the pericardium, I said the heart receives the plexus from T1 to T4. That's why the pain from the heart is going to be from T1 to T4. But now the pericardium receives its nerve supply from the phrenic nerve. So if you have injury to the heart that involves the phrenic nerve, that involve the pericardium, you are going to have pain also on the nerve root of the phrenic nerve. That's why at times with the heart disorders you have pain that radiates to the left arm. So and because the phrenic nerve supply, that is the C5, is supplies part of the brachial plexus that supply the arm. Are you getting? So those are the points that you have to know. That's for radiation. So before you speak about the radiation of a pain, you must always know that you should speak about the dermatome. You should know the dermatome supply of a particular organ. The next thing is again the radiation. When you also want to speak about radiation of the pain, you must know that all the retroperitoneal and the posterior mediastinal structure, that is all the structures, all the organs which are close to the spine are going to have all the structures which are going to are close to the spine are going to have a radiation of the pain to the back. All those structures which are close to the spine have their pain which is radiating to the back. That's what you have to point out. Okay, so radiation for R. A for, so I was on Socrates. S for site, onset, cramping, character, radiation, associated. A for associated symptoms. T for the timing. And under the timing you have intermediate or constant. If it is intermediate, you have to speak about how many episodes does the patient have in one day. When an episode comes, it has the duration of that particular episode. So those are the points that you have to bring it out. So the next one, after the timing, we have the exacerbation and the relieving factor E, and then S is for the severity. How do you bring out the severity? The severity of the pain, you just ask the patient to grade the pain 0 to 10. 0 is no pain and 10 is extreme pain, like labor pains in female. So those are the two pains that you have. So 0, he's going to tell you any number that's going to be between 0 to 10, and that is going to try to know the intensity, the severity of his pain, and that is going to be called the verbal numerical scale. We use it, the WHO use it as a routine. The next one now, which can be used also, we have the visual analog scale, where you show certain set of facial expressions to the patient, as emojis to the patient. So usually this is one which is used in pediatrics. So you have a child, you ask him how do you feel, so he's going to show you a set of emojis, and those emojis correspond to different number. These are emojis of pains. So he's going to choose his one, and then you take the number. That's going to be the severity of pain. Okay, the next one now that you're going to visualize now is a past history. Okay, the past history in the past history, we first start with the birth history, and under the birth history we have the prenatal history. In the prenatal history, you should know the mother's age and if the pregnancy was planned. You should know the number of previous pregnancy the mother had, and you can know it with the Gravit formula. That is a GNT PAL. You're going to see that more in obstetrics. You're going to know how was the mother died during the pregnancy. You should know these are all this you are trying to find is to try to rule out any congenital abnormality. Because if you have a child with congenital abnormality, you should take a very good prenatal history, and these are all the elements of the good prenatal history. What's the mother age, and if the pregnancy was planned? What was the previous? How many previous pregnancy did the mother have? How was the mother's diet during the pregnancy? Was she a smoker, alcoholic? Those are teratogenic factors. Were there any illness during the pregnancy? So mostly in the first trimester is going to be a particular problem, because that's the most common place for organogenesis in the body. So if you have a disorder in the first trimester, it's much more likely you are going to have congenital abnormality, which is very detrimental to the child. The next thing is, was the mother exposed to any radiation? It's a teratogenic factor. Did she take any medication during pregnancy? And medications which are teratogenic, for example, in which trimester? That's the first trimester. That's going to mostly cause the disorder. Example, metronidazole, which is used to treat anaerobic disorders which are located in the gastrointestinal tract, should not be used in the first trimester because it is teratogenic. So the medication usually that we use in pregnancy is going to be penicillins and beta-lactams. We don't use other medication other than them, except this disorder is very severe. This is very severe. When did she start antenatal care? Was it delayed? So from there you should know if the mother has already taken folic acid and iron. So folic acid, then the child, if she has not taken folic acid, the child is at risk of having a neuropathic disorder. Did she receive any tetanus vaccine? So that's one, you should know it. Tetanus vaccine is a routine for tetanus vaccine. The mnemonics for tetanus vaccine is 1611. So if it's 01611, that's the mnemonics for tetanus vaccine taking. So 0 is at contact, that's the first visit to the prenatal service. The first visit, that's contact. 1 is 1 month after, so she has to come 1 month after for the second dose. 6 is 6 months after the second dose, so she has to come 6 months after the second dose. 1 year is 1 month. 1 year, the next one is 1 year after the second dose. No, the next one is 1 year after the third dose. 1 year after the third dose, and the last one is 1 year after the fourth dose. So those are, she has to take in all 5 doses for her pregnancy. And then you have to know that what the first dose do not confer any immunity. The second dose confer a 3-year immunity, 3 to 5 year immunity. The third dose confer a 5 to 10 year immunity. The fourth dose confer a 10-year immunity. So just take 3-year immunity for second dose, 5-year immunity for the third dose, 10-year immunity for the fourth dose, and then a lifelong immunity for the fifth dose. So the next one is, how long was the pregnancy? Is it term, preterm, postterm? Are there pre-existing medical and psychiatric condition in the mother? Is there any blood group incompatibility between the parents? That's the resource incompatibility. That's when you want to have you have a patient that is jaundice and you want to know that. So the next thing, you have maternal problems or complications that can follow in pregnancy. If the mother is infected with Torch's infection, so the infection that usually causes congenital malformation are Torch's infection, that's the mnemonics. T for toxoplasmosis, O for others like HIV, hepatitis B, R for rubella, H for herpes simplex virus, E for Epstein-Barr virus, and S for syphilis. You want to know if the mother has certain diseases like gestational diabetes, which can prone the child to hypoglycemia or hypocalcemia. You have anemia, you have preeclampsia, which can predispose the child to intrauterine growth restriction and heart diseases. Abnormal vaginal bleeding, you have to know that, and you have trauma. Example of toxin which are teratogenic, you have alcohol, you have phenytoin, you have warfarin which are anticoagulant, phenytoin which are antiepileptics, tetracyclines which are antibiotics, and narcotics such as morphine. Maternal surrogate is associated with low birth weight and increased risk of obesity and diabetes in the offspring. So if you have a child with a mother with smoking, you have a low birth weight, increased risk of obesity and diabetes in the offspring. Then the next one is the natal issue. So the natal issue is the same as the labor issue, which is also in the birth issue of the child. So in the natal issue, you should know when the labor started, if it was spontaneous or induced, and if induced, why. Usually you are inducing labor that's the most common indication of induction is postterm, but we have other indication of labor that we're going to see in obstetrics. So where was the place of delivery? Was it at home or was it in a hospital? Who conducted the delivery? A doctor, a qualified nurse. All this is to try to visualize if there is any risk of infection or not, because the child may have neonatal sepsis. What was the mode of delivery? Was it vaginal? Was it cesarean? If it was vaginal, what was the intervention during the labor? Was it instrumental delivery? And if it was cesarean, what was the indication? What was the presentation of the fetus? So was it breech? Was it vertex? Was it face? Breech has an E. So what was the duration of the labor? Were there complications during the labor, that such as bleeding or failure to progress? So was there maternal fever, premature rupture of membrane? Did the baby have any cyanosis, asphyxia, birth trauma, meconium aspiration? When did the baby cry? So all those are the points in the natal history. Now in the postnatal history, you should know what is the birth date of the child, when is the child born. The second is what was the birth weight and the gestational age, what did they inform. And so let me just give you an example here in the natal issue. So example, you just say the labor started spontaneously at this week of gestation, and after that you say and progress for how long in which hospital. So that's for the labor. Labor started spontaneously at how many weeks of gestation, and progress for how long in which which hospital. You have already said these 3 points. The next one now will say the membrane ruptured. Was it artificial or spontaneous? The membrane ruptured spontaneously. The liquor, you speak about the liquor, that's the amniotic fluid. The liquor was clear. The liquor was meconium, to know if there is an acute fetal distress. The next one, after speaking about the liquor, we talk about the presentation. The presentation was breech, or the presentation was anything. You speak about the presentation. And then you speak about labor progress today. So how many hours later after the liquor rupture, labor progress? 5 hours later after the rupture of membrane, labor progress with the vaginal delivery of a live-term female baby who cried immediately after birth and weighed how many? So cried immediately after birth is here. Weighed how many is here with gestational age. So the next one you have to speak about now the postnatal. You have to know the initial Apgar score if the mother knows, and if so, what were they. So you need to know that usually there are 3 Apgar score that we take. We take the Apgar score at birth, the Apgar score after 5 minutes, and the Apgar score after 10 minutes. The Apgar score at birth is going to be, I'm going to tell you later what is the Apgar score. So the Apgar score at birth is to know the changes, that the physiologic changes, that's adaptation of the child to the out environment. The Apgar score at 5 minutes is for the prognosis of the delivery. So were there any restriction measures that were required? What was the method of umbilical cutting that was done? When was the feeding initiated? Did the child receive any vitamin K prophylaxis? So here you should know, to answer this question, you must know that you must know the post the care of the newborn. You need to know that the care of the newborn is divided into the A, B, C, D, G, E, F, H. So although they from A to H, that's the care of the newborn. A to I, sorry. So A call is for anthropometric measurement. Every time a child is born, you should do the anthropometric measurement. B for oily bath. Every time the child is born, you should do the oily bath. C for cord care. Every time the child is born, you should clamp and cut the cord sterilely. D for dressing. So you have to dress the child warmly. E for eye prophylaxis. Every time a child is born, you should place the child on tetracycline eye prophylaxis. F for footprinting. Footprinting is what you do out in European countries and in highly developed countries. In our context, you don't do any footprinting. G for so we have F, we have G for the Apgar score. You have to calculate the Apgar score. Then the next one is H for the heart rate, the respiratory rate, that's all the vital parameter and oxygen saturation. And then I is for injection of vitamin K. So all those are the elements that you must do when the child is immediately born. So when the child is immediately born, you have to go from A to I and you do all those elements. And if those elements are not done, you should bring it out inside your postnatal issue, like the child received vitamin K prophylaxis and even the eye prophylaxis if the child has now conjunctivitis. When was the first meconium pass? When was the first urine pass? So when was the first meconium pass? When was the first urine pass? How was the newborn hospital stay? Was there any problem during the hospital stay? So you have to speak about that. Where did he or she stay? So how was the newborn? Was there any problem in the hospital? Where did he or she stay? The nursery or the neonatal care to find any source of infection. So when was he or she discharged from the hospital? What was the age at the discharge? What was the infant cause in the first few weeks after discharge? Were there any sinuses, jaundice, seizures? So this is to find if the child is now presenting now with a new disease and you're thinking that the cause of that disease is a cyanosis, a jaundice, is a seizure, is a respiratory disease, an infection. Was there any congenital anomaly or a birth injury observed during the neonatal period? So those are the points that you have to put. So you have known passage of meconium may imply intestinal obstruction. That's the point. And the most common intestinal obstruction that you can have in a newborn is a megacolon, which may be coming from a Hirschsprung disease or not. So you have delayed meconium passage is when meconium is passing after 24 hours and may suggest a cystic fibrosis. And you have a cystic fibrosis if you also have a recurrent chest infection. So a delayed meconium may suggest a cystic fibrosis or a megacolon. That's a Hirschsprung disease. Absence of urine voiding in the first 2 days of life may suggest a renal agenesis or urinary. So in the first 2 days you may have renal agenesis or urinary system obstruction. And the point to also bring out is that cystic fibrosis is much more common with wide ethnicity. So you have to bring it out. And then in the black ethnicity, that's in our context, you don't usually have cystic fibrosis. It's going to be very rare, so that you have it. But if you have it, you should point out. So you have the past medical history and surgical history. So it can come after those developmental vaccination issues. So in past medical history, how was the child previous did the child experience similar symptoms or attack in the past, like the symptom that is presenting with? Were there previous visit to the doctor? Were there admission to the hospital? From what child illness and infection has the child suffered? Was there recent exposure to infectious disease? That's chickenpox, measles, pertussis, mumps. It depends on what you are suspecting from your issue present complaint. Currently, is the child on any medication? Why? Are there any allergies? So all to the point that you should bring out in the past medical and surgical issue, and if he has been operated or not. If the child has a procedural intervention done, you should know with the results that that's a past medical and surgical issue. So a history of recurrent diarrhea, respiratory tract infection, sinusitis associated with failure to thrive, inspire good feeding strongly suggests cystic fibrosis. That's another element for cystic fibrosis. Recurrent diarrhea, respiratory tract infection, sinusitis, and failure to thrive with a good food intake suggests cystic fibrosis. Acute wheezing in a child with similar attack suggests bronchial asthma. So we are going to see all these elements when we are going to visualize the particular symptoms. Now the medication issue. So you need to know that certain medication can prone to infection. So these are the points that you should say on medication. What's the drug name, the route of administration, what is the duration of treatment, what is the dosage of and timing and all that. You should say all these elements when you are taking your issue, when you are taking your medication, and you must say it if you are suspecting that a particular medication is in the course of the disease of the child. Okay. So has there been the recent long use of antibiotics? Because the antibiotics can prone you toward Clostridium difficile diarrhea. So you have to know it. So you have, are there any allergies to drug food or bed? Are there to particular drug food or even bed? So are there any known medicines or known prescribed medication, herbal preparation? Ask about drugs that may be relevant to the current condition. That anticoagulant may cause bleeding tendency, NSAIDs may cause gastric ulceration and upper GI bleeding. So all these are the elements. If the child uses home nebulizers, you must know the method of mixing and administrations of the medication and TB. So if the parents say that their child has a chalk allergy, clarify exactly what they mean by allergy. So if they are talking about allergy, you should clarify, because usually allergy presents with urticaria. That's going to be a rash which is pruritic with raised margins. So if you have that erythematous raised margins, so you should try to clarify the word allergy. That's allergy usually present with those rash. Or you can have allergy in the upper respiratory tract which present with tearing, like you have tearing from the eyes and red eyes, you have pruritic ears, you have sore throat. So those are the elements that you can also have, and you have sneezing, recurrent sneezing. So that is upper respiratory tract allergy. Allergy to drug is often over reported by the parents, so you should try to clarify it. A penicillin skin test, and if you have an allergy to penicillin, a penicillin skin test has to be done. That is, a small amount of penicillin is injected underneath the skin, and you are going to see now the level of induration. So some few days later, if the level of induration is less than 4 centimeters, it means that the child is not allergic. So the next one now is the developmental issue. So in your developmental issue, you need to point out the fact that you have the Denver score, which can help you much more in the developmental issue, and there are certain elements in developmental issue. That's the gross motor, the fine motor, the social development, social and personal development, and then we have the language development. So in the gross motor, you have to know if the child has raised the head wide prone, if he can hold straight, if he can roll over, if he sits without support, if he crawls, if he crouches around furniture, if he walks independently. So, and when you have each of these elements, you should write the month. For the fine motor, you should know follow the face to midline. If he can follow a face to a midline, if he reaches a toy, he can hold a toy. If he can grasp a palmar grip, I'm going to explain this later. If he transfer a toy from one hand to the other, so all that you say it, and then if he scribbles, that's writing like gribouillage on this book, so you write it, and you write the month, the particular month that he had it. So the next one, so this is very important. The child that has cerebral palsy, so you have to bring it up in all these elements. The next one, you have social and development and personal issue. If he smile when you smile to him, if he smiles spontaneously, if he put food in his mouth, if he has fear of strangers, if he plays symbolically, if he drinks for a cup, if he waves bye-bye to other people, if he recognizes his mother and recognizes certain people, if he says that feels, that's social. Then the next one is language. Language is when he first started making his first sound. So that's the first sound, when he babbled, when he first started saying ma, first a 2-letter word. When he first started saying, when he first started next starting a 4-letter word like mama, dada, 2-syllable word. So first he started saying understanding command, when he started understanding command, when he started recognizing his name. So all these are language. Okay, so that's the developmental issue, and we're going to specialize more on that when we're going to do the Denver score and elements particular for the developmental issue. So the next one is immunization issues. It's also very important to know the expanded program of immunization, and the expanded program of immunization, I'm going to give that when you're going to do the vaccination. So, and you should know all the elements of expanded program of immunization, because you can have a patient with measles and you have a patient that has not been vaccinated. You should know it. Is a child up to date with his vaccine? Very important. Were there any miss or mutant vaccines? Were there any adverse event? And every time you're speaking about this, the mother should try to bring out the vaccination card for you to see. Is there any allergy to any vaccine? If so, which vaccine and what is the allergy? Did the child receive the booster doses of the vaccines? If so, what were they and what did they receive? So that's why you should have the vaccination card. Did the child receive optimal vaccines and all that? So it is very important to see any related documentation. That's immunization records. That's what I said. In a certain part of the world, you may need to ask the BCG scar. So you have the BCG scar also on the left upper anterior forearm. You may see the BCG. So usually when you want to report, you say the child has received all the vaccines. The child has received all the vaccines according to expanded program of immunization. till date, and then you say where you have seen the vaccine, the BCG scar. The BCG scar we're seeing on, in our context, we have the BCG scar on the left upper aspect of the forearm, the left upper third of the forearm. That's where we are usually vaccinated for BCG in Cameroon. In many countries there are multiple national immunization, but here we have the expanded program of immunization. So that is going to be divided into at birth 1, the second is after 6 weeks, that's 1.5 months. The next one is after 10 weeks, that's 2.5 months, and the third one is after 4. The fourth one is after 14 weeks, that's 3.5 months. Then the next we have after 6 months, then is after 9 months, then after 15 months. So those are the different parts on the expanded program of immunization. Then the next one now is the feeding of the IgE. If a patient that has failure to thrive, you must take all the elements of the feeding and the IgE. So the feeding and the IgE, we have the feeding for an infant and for an older children. For an older child, for an infant, you may have feeding in breastfeeding, or you may have feeding with artificial feeding, artificial milk. So in breastfeeding, what's the duration of exclusive breastfeeding? Usually it has to be for 6 months. Is the breastfeeding on demand or scheduled? What is the frequency of the breastfeeding? How often? And the time, the frequency and the time of the breastfeeding. Good breastfeeding has to go up to more than 15 minutes in order to remove all the highly nutritive proteins which are coming later in the breast milk. How often does the child feed at night? What is the duration of each feed? What is the feeding technique the mother uses? Does the mother use both breasts for feeding? Is the feeding adequate for the child? Is there excessive weight gain passing urine? Is there excessive crying? Are there any feeding difficulties? Are there worries regarding the breastfeeding? Does the mother wash her hand before and after feeding? Did the child receive vitamins and mineral supplementation? Did the mother start complementary feeding? So all that is very important. Tips of breastfeeding. There are many feeding positions, but the one that you should adopt is the one which has a very good attachment or a proper latching. So I'm going to speak about that later. The infant faces and the body should be close to the facing breast. So that's the first thing. When you do a position, the infant face and the body should be close to and facing the breast of the mother. The next one is the infant body should be supported straight in the same plane with the head. So the infant body should be supported straight in the same plane with the head. The infant chin should touch the mother breast with his nose opposite to the nipple. The infant's mouth should be wide open with the lower lip everted and much of the alveolar inside the mouth. Remember the essential component of infant's proper latching, that's attachment. So when you are the essential components are going to be a wide open mouth to say that the child is well attached to the breast. The mouth should be wide open. You should have everted lower lips. You must have the most of the areola of the mouth, the mother should be inside the mouth of the child, and you have chin touching the breast. So that is proper latching. Breastfeeding should be started as early as even half an hour, so 30 minutes after delivery. It is preferred for the 2 years of life exclusively for first 6 months. No water should be given. So for the first 2 years or so exclusively you have to do breastfeeding for 6 months, but first 2 years of life is going to be very good. On demand feeding means every occasion the child wants, and it's very good. Initially, breastfeeding baby suckles for 5 minutes on each breast, and this process is repeated every 1 to 3 hours. So you are giving breastfeeding every 1 to 3 hours to the child, but that is at the beginning. You can first plan the child, and then you schedule first the time of the child, and then later on the child is going to be on demand. So you have most newborns sleep for up to 5 hours. In this period of time, they will not need to be fed. So adequacy of breastfeeding can be assessed by adequate weight gain. So the adequacy of breastfeeding can be 1. Adequate weight gain. 2. Adequate sleeping, that's at least 2 to 3 hours after every feed. 3. We have voiding of urine, that is 6 to 8 times a day for breastfeeding. Passage of loose stools, at least 4 times per day. But you have to know that in breastfeeding babies, you may have stools which are passed once every 3 to 5 days, which is still normal. Up to 10%, that's 15% of preterm newborns of birth weight may be lost. So you have 10% of your birth weight may be lost for the first week, and then you regain it all the 10% after the 10th day of life because of the adaptation. So by 4 to 5 months, you're going to double the weight. By 1 year, you're going to triple the weight, and the weight gain as from the first 3 months is going to be 30 grams per day. And there's a particular formula for the weight of a child. The formula for the weight of the child when the child is less than 1 year is going to be the age in month plus 9 divided by 2, all divided by 2. The formula when the child is between 1 to 6 years is going to be the age in years times 2 plus 8. Age in years times 2 plus 8. That's the weight. The weight between 1 to 6 years. Then the weight greater than 6 years is going to be the age in years times 7 minus 5 divided by 2. Age in year times 7 minus 5 divided by 2. So that's it. So the next one is the frequency of uninterrupted breastfeeding at 9 or that. So we have vitamin D supplementation, which is supplemented in our context with uvesterol. That's vitamin ADEK, ADEK. And then the next one now is formula feeding. So if you are not giving breastfeeding, you may give formula feeding to the child. So the formula feeding, when did it start? So what's the type of milk that you use? Is it NAN, which is in our context and all that? How is it prepared? What is the mode of feeding? How much milk does the child consume in each feed? What's the volume of the residual milk? What is the frequency? So all these are the elements that you have in formula feeding. And with this, the next one is as the guide principle of formula feeding need to be discouraged. Usually formula feeding has to be discouraged. Just that some mothers saying that they are too busy, but the best one is breast milk. So the frequency of formula feeding is variable. So it's on demand. It can be on demand, but the best is when it's on demand. And you may have 6 to 9 feeds per day. So, and you may start at the beginning with only 30 to 90 meals. 1 ounce is 30 meals. So you have you give the child every 3 to 4 hours till the first week arrive. So unmodified cow milk and honey should not be given to a child of less than 12 months. So those cowed milk and honey milk which are unmodified should not be given. Then the next one is weaning. So weaning is when did you start introducing solid food into the child's feeding protocol? So that's weaning. So introduction of semi-solid food to the child's protocol. So when you want to introduce semi-solid food to the child protocol, it has to be bit by bit. So the WHO define the complementary food, any food whether manufactured or locally prepared, suitably for the complementation to complement the breast milk or as substitute. You have to know that after 6 months, the child do not only depend again on breast milk. You have to receive iron. He has to receive other food supplies again. So the child should not only receive breast milk. So by that time now, you should start now complementing the child with other food. So when you complement the child with other foods, you have to know that suitable time for food introduction is 6 months. That's really. New food introduction should be placed one at a time. So you should not start so with all the food at the same time. You should place one at a time, and you monitor for 2 to 3 days and to find if there's any allergy for 2 to 3 days. So you start with first things like potato, punch potatoes, you Irish potatoes, you give it to a child, you find if it is allergic to that, then you progress to another food. So you introduce bit by bit. So you can punch now rice, you punch fufu in our context. So the addition of salt and sugar to complementary food should be avoided. Addition of salt and sugar to complementary food should be avoided. Introduction of food with high allergenicity, such as egg white. Egg should not be given at the beginning, so that's less than 12 months. You should not be given, or less than 1 year. Egg white, berries, nut should not be given because they have high allergenicity. So you should only introduce it after 1 year. Introduction of complementary food should be soft. It should be fresh, homemade. It should be affordable, easy available, and well tolerated. Okay, for older children now, so you should ask what was the child food intake during the first 24 hours. So is this when you are thinking of a food poisoning or a gastroenteritis? So how was the meal and snack per 24 hours? What is the current composition of the child diet? What are the favorite food for the child? Is the child forbidden to have particular food? So you have all these elements that you can use for older children. Then the next one is the family issue. So generally in the family issue, you should say that the child is a which position in a family of how many, and after saying that, you have to say now the child is a which position in a family of how many. After that, you say if he has siblings, and if there's any family issue of a particular disease. And you can have atopy. Atopy is a triad of treating asthma, allergic rhinitis, and an allergic dermatitis. So those are it. And you can draw it on your family issue. You have to know that there is a difference. You have first degree, you have second degree, you have third degree. First degree is the parents, is the siblings, your brother, your sister, so that's the first degree. Or parents or children. So when it's one generation up or one generation down. So your brother, your sister, your parent, and your children is first generation. Now second generation now is your uncle, your aunt, your nephew, your niece. So it is a bit farther than you, and your grandparents and your grandchildren. So that's the second generation. First generation is your parent and your sibling and your children. So it's coming and they're directly related to you. Now second generation is uncle, aunt, nephew, niece, grandparent, grandchildren. That's, you have 25% of and then the third generation, you're going to have first cousin, you have the great grandparents, great grandchildren. That's the first generation. And now family issue is very important also for consanguinity. So this also goes for degree of consanguinity, where you have 50% of gene transferred, 50% of similar gene transferred with first degree. So if you have a family issue of sickle cell, it's going to be highly transferred. If you have consanguinity, 50% of those genes are going to be transferred in first degree. Second degree, you have 25% of those genes transferred in second degree, and third degree is 12.5 transferred in third degree. So the next one is the social issue. So in social issues are all the elements that you have to put, but generally you just say that the child lives with who, in which house. So you need a 3-room house which is rented or not. You have to put it that way. So and then you continue now by saying the number of occupants who are in that room, and then you speak about that. So So that's it. So these are all the elements, particularly if you have a problem with the social history, that this patient is an introvert, he doesn't want to speak with the other children. So those are the elements that are supposed on the social history. Okay, the traveling represents an important source of infectious disease such as hepatitis A, typhoid. So in our country, when it comes to sub-Saharan Africa with tropical zones, so where it's going to have you have a high rate of this disease, typhoid fever, tuberculosis, poliomyelitis, cholera. So when a patient travel into this area, tropical zones, he must be treated with this. But when traveling also out of this zone, so the temperate zone, it's also at the risk of certain diseases which are much more predominant there. So it depends on the zones where the child is. So that is going to be so it's going to contact different diseases. Contact with animal can transmit any diseases such as brucellosis, salmonellosis, toxoplasmosis, and rabies. So now we have the review of system. So in review of system, we try to review all the other elements. We're going to have the general system, that's the general health of the child, the sleep, the activity, if the child plays as before, if the child eats as before, if the child has any fever. So those are the elements that you have to put on the general. On neurologic, you have to put if there is any headache, if there's any dizziness, vertigo, fainting. That's one. It's a child who is older that can tell you this one. Also with other element, you have visual disturbance, ocular pain, itchy eye, red eye, and all that. Ear, nose, and throat. You have all these are the elements that you should put. So we are now going to continue with the other elements that are going to help you in your history taking. From there, we can say thank you for your kind attention, and you're going to continue with the next tutorial. Thank you.